Everyone in India, I think it will be evening. So good evening, everyone. And yeah, thanks, Vengi. Thanks for giving this opportunity, and thanks, Murali, sir, joining in as well. Um, the topic, in fact, I should have started this a month before. That's where we planned, Vengi and myself, but because of my personal circumstance, I think it's a bit deferred. Yeah, it's about pharmacokinetics and pharmacodynamic implications in antimicrobial use. Uh, what I wanted is it's we can antimicrobial. We need to include antiparasite as well as antiviral, which we deliberately just excluded because to just make it concise. Now we discuss more about antibiotic and antifungal, but some transgressions will be there. I can't be very specific, so let's move. So importance of PKPD. PKPD, that is pharmacokinetics and pharmacodynamics. We generally refer to all pharmacological agents, and usually for antibiotics, it's a relatively newer concept. The reason you apply this is to preserve and increase the efficacy of existent antibiotic. Use the pharmacology and microbiology knowledge and background to optimize antimicrobial use and clinical outcome, and to minimize toxicity. And most topical now is resistance issue, to just curb resistance issue. So what are our objectives? Describe the pharmacokinetics and pharmacodynamics of commonly used antibiotic. Summarize contemporary applications of antibiotic pharmacokinetics and dynamics, and what way clinicians it can be useful. So pharmacokinetics, in short, can be just summarized using this ADME, which is absorption, distribution, metabolism, and elimination. Absorption is from the site we administered. If it's oral, from the gastric absorption up to delivery into the systemic vascular compartment, and then distribution from the central vascular or intravascular to all the tissues where we expect it to be moved, and then metabolism of the antibiotic, and lastly, elimination. So if we administer it IV, you get 100%. We start with 100% concentration. Since directly the bolus is going into parenteral route, you start with 100% and then slowly it comes down. When it's oral, it's usually starts from 0, reaches a peak, and then again plateaus back. So pharmacokinetics, in short, from absorption, if it's oral, first pass metabolism through liver and then bloodstream, eliminated renally. When it's given parenteral, it's straight into the bloodstream. It gets distributed to the tissues we focus where we want to use it, and then renally it's excreted. So routes of administration. In this case, routes of administration is most of them are when it comes to antibiotic, it's oral and IV. In UK, we use IV predominantly, intravenous. Intramuscular is rarely used. Likewise, nebulized colomycin, nebulized we use nebulized tobramycin. These two are nebulized form. And intrarectal, rarely we use for C. difficile, intrarectal metronidazole or vancomycin is used. So apart from that, administration, intrathecal, sometimes if you have ventriculitis, that's where we go for intrathecal. There are other, like intraocular, when you get endophthalmitis. Likewise, in our case discussion, I will mention about intrapleural administration as well. So roughly, after oral administration, as you know, it goes through the portal circulation to the liver, where we have this first pass effect, whereas parenteral antibiotic bypass this. And time in GIT as well. There are sometimes if you have gastrointestinal intolerance, vomiting and diarrhea, you give parenteral antibiotic. Likewise, after all this administration, what you achieve systemically is your bioavailability, which is most important. For each antibiotic, you have to look at how much bioavailability is there for the antibiotic to be effective. So tissue compartments, finally, what you're looking at is from capillary to your target tissue. So we will just we'll just look at all the compartments. You have plasma where the initial administration goes in. From there to the interstitial tissue, intracellular, transcellular. In transcellular, you have intraocular, peritoneal, pleural, and synovial, and then fat. So what are the barriers for these? Between plasma and interstitial, you have this endothelial barrier. You have the plasma membrane, which acts as a barrier between interstitial and intracellular. And you have all the receptors, which convey transporters and addition molecules, which convey all the substances intracellularly. And then you have the specialized barrier, like your blood-brain barrier, which lets in our case, it's the antibiotic into the specific target, where if it's CNS, it's through the CSF blood-brain barrier. Likewise, synovial fluid, pleural fluid. We have to look into that to be to our antibiotic to be effective. So lastly, endothelial cells. As you can see, the last capillary endothelium, kindly take notice of this molecular mass. Solutes with 500 to 600 Dalton can be let out. If it's above this size, your molecules won't go into the tissue. But there are exceptions where you have disruption due to inflammation. Like if you have meningitis, you will have all your antibiotics penetrating. In spite of the size, you will have the all the antibiotics going in if there is inflammation in the meninges. So, but apart from that, mostly the antibiotic will be confined to the intravascular space because of the endothelial barrier. So, most important concept we use when it comes to pharmacokinetics is volume distribution. So, if you want, if you have the concentration in plasma, the amount of total amount you give by volume distribution will be the concentration. But what we do is we want to calculate the VD. So we exploit, we conversely do VD, just inverse it. VD is equal to X by C, where X we know it is the amount we administer, and then concentration we know how much we give. So using this, you can calculate the volume distribution. Volume distribution will roughly give you an idea of whether the antibiotic we give is predominantly intravascular, does it go intracellularly, because ultimately what we are aiming at is tissue concentration, where exactly if you have osteomyelitis, your antibiotic should penetrate to the bone. Likewise, if you have endocarditis, it should penetrate into the vegetation. So like that. So you are targeting based on volume distribution, you can roughly predict whether we will achieve our aim. So this is roughly what I was saying. So total body water is 42 liters from our physiology days, you might notice. And this is one reason, this is what I want you to observe. These are all applied. Your physiology, practically if you apply, this is where it comes into play. All the things you read in physiology is used here. So plasma, roughly it's 3 liters. Interstitial, you have 11 liters. So when your volume distribution roughly equates to 14, you can predict that particular antibiotic you're using is predominantly intravascular and tissue concentration is not achieved. Suppose if it's going beyond 14, then you are getting some amount of intracellular concentration, where if your target is to treat one of the tissue, it will help. And then transcellular, again, this is very important, and it's individual case-by-case basis. Likewise, if it penetrates into fat, it will be still further, it will be VD, that is volume distribution will be very high. Classic example is gentamicin, aminoglycoside. Suppose if you are giving 20 units injection and you get a concentration of 4 units during the beta phase, you calculate the volume distribution, which will roughly be 15 liters. This is exactly what I mentioned earlier. So you clearly see it's predominantly going to be an intravascular agent. And gentamicin, it's an aerobic antibiotic. That again, you must appreciate. When there is an anurobiasis, there is an abscess or a collection deep within, gentamicin won't act. So in these instances, it won't be effective. Gentamicin will be effective in case of biliary sepsis, urinary tract, because the concentration achieved is very high in these sites. But sometimes they use for consolidation in lung infections. It won't be effective. Likewise, if you have a deep abscess deep within where you have anaerobiasis, pH is low, gentamicin won't work. And as you can clearly see, you can predict that with this volume distribution here, when it's 15, it's predominantly intravascular. So it will work when you have vegetation endocarditis, because heart is also part of our circulatory system. So it's also, you should consider it as intravascular. So what are the antibiotics with high volume distribution? Azithromycin, rifampicin, these are all antibiotics with high volume distribution. Azithromycin, especially for intracellular infections, it's very useful because it goes intracellular. As you can clearly see here, volume distribution is 40. So it's beyond 15. All these antibiotics will be helpful for us. Rifampicin is 53.2. Likewise, using volume distribution, you can predict whether our antibiotic will work in case of intracellular infections. So, drug binding to protein and tissue. Like, since once you give the antibiotic, there will be plasma protein binding. So once that is, some antibiotics are well bound to plasma protein, like ceftriaxone. Ceftriaxone is protein bound. So these antibiotics, you have to be careful. The dose you give must be appropriate, so that the antibiotic that is free antibiotics are the ones which will be active when it is bound to plasma protein or interstitial or intracellular protein. Your free antibiotic is not available to work. So that we have to keep in mind when we have a highly protein-bound antibiotic. But there is an advantage to that. The half-life will be prolonged. You will have for ceftriaxone, ertapenem, teicoplanin, your half-life will be quite sustained when you have a good protein binding. Likewise, tissue binding increases volume distribution, which classic is chloroquine. Chloroquine, this is the exception I mentioned earlier. It is antiparasitic, but as you can see, the volume distribution is quite phenomenal, 13,000. And it's a very interesting agent in that intracellularly in lysozyme, it is used for alkalinization. What in UK, during this April season, it's called lambing season, we get Q fever. For Q fever, you use doxycycline. If you use doxy on its own, sometimes it won't be effective in Q fever when it forms intracellular forms, where you have to alkalinize the lysozyme, for which in Q fever, sometimes in endocarditis, in Q fever, they use doxy plus chloroquine for this purpose, which is unique because of its, again, its pharmacokinetics. We just exploit this. So plasma binding decreases, plasma protein binding decreases volume distribution. It's very clear, isn't it? Within the intravascular compartment, if it's bound, the antibiotic is not free to go outside the vascular compartment. So it does decrease the volume distribution. So what are the plasma proteins? The main ones are albumin and alpha-1 acid glycoprotein. And beta-lactam, like I mentioned, ceftriaxone is bound to plasma protein. Because of that, its half-life is increased, but the free amount of antibiotic is less. The same with alpha-1 acid glycoprotein, which is sustained when there is inflammation. It is acute phase reactance. Because of that, you get quite an increased amount when there is inflammation. So major sites of metabolism, liver is predominant site, as we know, all this modern detox culture. Liver is the main organ for all the metabolism of antibiotic. Apart from that, you do have small amounts in small intestine, lung, plasma, kidney. For example, in lungs, daptomycin in earlier days, they recommended not to use because the pulmonary surfactant will inactivate daptomycin. For that reason, it was not recommended in pure infection, tracheobronchitis like that. And now it's validated, and right-sided endocarditis, we do use it. So, and then you have kidneys. The next to liver, kidney is one of the predominant organ for metabolism. So what are in the liver, you have phase 1 and phase 2 metabolism. The drugs initially, the cytochrome P450 pathway makes all the drugs into active form. And phase 2 makes it, it conjugates and makes it inactive and water soluble so that it can be freely excreted. But we do exploit this phase 1 activation in some situations. For example, antiretroviral therapy, you have darunavir with what you call boosted protease inhibitor and ritonavir. If you add both together, the darunavir, daltigravir effect will be increased, boosted because of this. We do exploit in certain things. Likewise, antiviral, valganciclovir, it's a prodrug, gets activated by this pathway, and then you get ganciclovir. Similarly, in case of acyclovir, you have to give 5 times. We do have valacyclovir, which comes as 1 gram tablet. You can give it 3 times a day. After initial, in herpes encephalitis, you can give IV. After 7 days, you can switch to valacyclovir and complete the course. Suppose you are giving it. And phase 2, as I mentioned, it's conjugation. So phase 1, cytochrome 450 pathway, it's a unique one. It's interesting. It's an iron-containing monooxygenase. And for us, antibiotics, when it comes to antibiotic, COP 1, 2, 3 plays a predominant role. And just a minute, I'll just have some water. The most important feature I want to raise here is cytochrome 2C19, which when it comes to infectious disease, it interferes in voriconazole pathway. Likewise, systemic drugs, clopidogrel, it does interfere in that. And as you can clearly see, there is genetic predisposition to it. And there is also ethnic whites. You have loss of function mutation in 20 to 30%. Similarly, East Asian, particularly Chinese. I used to work in Singapore, where we used to have this pharmacogenomics, where they used to look at when they use voriconazole, they always check patient doesn't have loss of function mutation. Likewise, you can classify them as extensive metabolizers, intermediate metabolizers, poor and ultra rapid metabolizers. So this is in short all the CYP3. They are poor substrate selective agents. They have a large fluid binding, and they have the apart from the 1, 2, 3, we have the endogenous molecules which are also metabolized by this pathway. So phase 2, it's more of conjugating molecule, that is chemical molecule, like sulfotransferase, glucuronide transferase, glutathione, N-acetyl transferase, and methylase. Aminoglycoside most often is, as you might have seen, mutation will be N-acetyl transferase or methyl transferase. These are the sites which involves when it's mutated. You have resistance to gentamicin. With this is within bacterial, not. So the last one among the pharmacokinetics is excretion. As you know, renal filtration, roughly renal plasma flows is 625 mils, out of which you have 500 going through the efferent arteriole. So 125 is filtered and reabsorbed. 124 is reabsorbed. 1 mil is excreted through the urine, and you again recover fluid. In the end, you have 624 ml out of the 625 filtered, uh, of which large proteins are not filtered, they are retained, and usually water molecules and small molecules are filtered out. And there is secretion, peritubular capillary secretion, and this secretion also helps in antibiotics to be secreted back into the tubule. As you know, there are two pathways, tubular secretions. You have organic anion transport, likewise organic cation transport, and ATP binding acid proteins, which also help in. Uh, Especially, we are interested in organic anion transporters. As you know, you can use probenicide to increase penicillin systemic serum concentration. Likewise, in systemic diseases like gout, you use probenicide for as a uricosuric agent. So this is the site that is used. Uh, when there is good protein binding, tubular secretion is not altered, but the antibiotics are, they do go across the barrier. So because of that, initially protein-bound antibiotics are released when the antibiotic moves into tubular secretion, and then you do have available further antibiotics to uh, for the tubular secretion. So you do have reabsorption as well, which is predominantly by diffusion, and usually lipophilic drugs goes through this pathway. So again, the other, this is renal excretion. You have biliary excretion where you have this enterohepatic circulation, and the drug, like we mentioned earlier, is conjugated, and especially glucurinated conjugates are passed through bile into the feces, small intestine, and then excreted. Some of them are excreted. Biliary excretion is also well known, and some antibiotics we do utilize this pathway. Antibiotics which use this pathway for renal impairment. In patient with renal impairment, you use antibiotics which are excreted through this pathway. So drug elimination, as I mentioned earlier, you have this metabolism in the liver by phase 1, phase 2, and then you have drug-drug interaction. You can use this pathway. There are certain induction of metabolic enzymes like grape juice. You have rifampicin will induce and bring down other uh, uh, pharmacological agents down. Likewise, antifungals will inhibit and make the toxicity of other agents come out, like arrhythmogenic agents. You would have noticed that. So water soluble drugs can be excreted both in urine or bile. So ultimately, what's our with pharmacokinetics? What do we achieve? It's we need a therapeutic concentration, but we want to avoid a toxicity, and it shouldn't be subtherapeutic. This is our ultimate goal. So this is what, in short, we are achieving with pharmacokinetics, all the ADME. Initially, you achieve a peak, and then there is elimination. You can, for convenience, you can divide them, even though in strict sense, it's not compartmentalized. You do have a central compartment, and from there, the peripheral compartment are targets which we want to achieve specific. And pharmacodynamics, by which here it's unique, since it's antimicrobial. It's the what we are targeting is the organism. That is our pharmacodynamics. But you do have collateral damage, which is toxicity, and because of the drugs, some drugs they are having collateral damage, like the same pathway does affect humans. For example, antifungal like azoles, since they utilize P450 pathway, human P450 is affected, you do have hepatotoxicity. So similar things with pharmacodynamics, what we are looking at is more of a potency of the antibiotic and antimicrobial issues. Here comes our microbiology aspects. In vitro, what does the lab help you? They look for resistance. They look for your antimicrobial susceptibility, that is growth inhibition or complete kill of the organism. So this is in short to summarize everything. By pharmacokinetics, we just quantify the exposure of antibiotic. Pharmacodynamics, your antimicrobial effect, post toxicity and resistance, and the which includes drug potency, drug concentration, and effect. So initially, you administer the dose, you achieve concentration versus time in the serum, and for the host, it's the pharmacological or toxicological effect. For the organism, it is antimicrobial effect, and how much time you achieve. So in short, this is pharmacokinetics and pharmacodynamics when it comes to uh, antibiotics. So now I go to microbiology proper. This diagram is to help you understand what exactly is colony forming units. These are individual staphylococcal colonies, and in urine, it's most commonly used. It's called semi-quantitative method, where you just divide this into 4 quadrants. And this is the inoculating site. From the loop, you pick the organism, and from here you streak it. So if you have growth in all the streaks, then it's roughly 10 to the power, significant bacteriuria. So it's more than 10 to the power of 5. If it's just in 3 quadrants, 10 to the power of 4 to 5, it's a rough way of calculating. So later on, we have this colony forming unit. If you have any doubts about it, this is what we mean. So in the lab, what we do, we identify an organism, and based on the organism, we do sensitivity. You have standard antimicrobial incorporated into filter paper, which is placed on the disc where you have already sweep the organism, and you have a zone diameter for each organism based on standard cutoff. You have a zone diameter. If it's less than the zone diameter expected, it is resistant. If it's you have a free zone, then it is sensitive. Here you can see erythromycin is resistant, penicillin is resistant, vancomycin you have a good zone, fusidic acid, trimethoprim, gentamicin are sensitive. So that is this is more of a qualitative result, sensitive or resistant. You need a quantitative result as well. In treating endocarditis, a deep-seated infection, you need to know the minimum inhibitory concentration, which is achieved by this test. This is called E-test, epsilon test. Here you see, as an example, E-test for ESBL. This is cefotaxime, and you can see the colonies encroaching into this ellipsoid zone. Whereas here you don't see, because of clavulanic acid, it has inhibited all the organism. And here the MIC is 2. As you can see, this ellipse joins roughly at 2. This is 2 microns. That's the two, and then here, as you can see, it's fairly sensitive. It's 0.19. So when you do it in a lab, this is how we do. You have a bacterial quantity, uniform quantity of bacteria in each tube, and then you have a serial dilution. You look at visibly using spectrophotometry. You look at the exact site at which the color change happens, and this is called minimum inhibitory concentration. But if you subculture on these subsequent sites where there is no color change, there will be growth. And then there will be a point at which there will be no growth. That is called minimum bactericidal concentration. Between this MIC and MBC, there is an in-between point that's called mutation prevention concentration, MPC. And the point between MIC and MPC is called mutation prevention window. If you look at all the CLSI as well as UCAST cutoffs now these days, they are revising the MIC cutoff. This is based on now our target is to move away, even prevent a mutation in our dosing regime. That's what we are trying to, and that's what we achieve. This is what describes that. So in addition, what are the issues we have in the lab? Sometimes you will have multiple organisms on the same culture, which is difficult to give you a sensitivity, for which we have to isolate individual organism. You need a purity, and then subsequently you have to come up with the MIC. And earlier, Vitek2, this is one of the automated systems for sensitivity testing, and had issues. Now it's been corrected. We do still have vancomycin, MIC creep for Staph aureus, which I will come later, and newer agents like delofloxacin, which is a new quinolone, which they claim will be effective. Usually, quinolones won't be effective in deep-seated abscess and anaerobic environment, but because they have changed the charge of the this quinolone delofloxacin, it's said to be effective in abscess. But again, they don't supply this delofloxacin strips to test. So that's existing issue. Once the the companies also supply these antimicrobials for lab testing, it will be quite useful. So this is a gram stain, which you might have come across in microbiology. And here you have gram-positive cocci in chains, which is Streptococcus. This is staph in clusters. This is a gram-negative bacillus rods, gram-negative rods, and this is yeast. Gram-positive cocci, and the size typically you can make it's a yeast. And this, again, apart from pharmacodynamics of antibiotic concentration achievement, one more thing. Some organisms are intracellular, as well as you have this distinction, gram-positive and gram-negative. Since the cell wall differs based on gram-positive or negative, your choice of antibiotic also differs. The major difference you need to appreciate is this outer membrane, which is predominantly lipophilic. So you need to make all your antibiotics lipophilics in order to reach this periplasmic space, which is a controlled milieu. And because of that, in gram negatives, you have beta lactamase very effectively managing resistance issue. Whereas in gram positives, the peptidoglycan is large and easily available for the antibiotics to act. So large molecules like vancomycin, teicoplanin, and act on gram positives. Likewise, fluclox, all the cloxacillin, which can't, not much lipophilic, but acts on the gram positives. This is the key difference you need to appreciate. Yeah, and antibiotic-wise, what are the pharmacodynamic parameters we need to achieve? There are antibiotics which are concentration dependent, and there are antibiotics which are time dependent. So this is most important. For example, beta lactams, all the penicillins, cephalosporins, meropenem, carbapenems, all of which are time dependent. Linezolid, tetracycline, and cotrimoxazole, all of this antibiotic, you have to keep the antibiotic 4 times that of MIC, so that it is active. Whereas in case of aminoglycoside, you can give once a day, as long as you achieve a peak, that is more than enough. And then there is an intermediate class of antibiotic, fluoroquinolone, macrolide, and glycopeptides, which area under the curve by MIC is the parameter we use. And here you can see post antibiotic effect, which is again the organism remains stunned during this phase, where it's you can the thing is, it after this post antibiotic phase, it will again regenerate and start growing. So there are some antibiotics which have a good post antibiotic effect, which we can use, like aminoglycosides have a good post antibiotic effect, and this adds to the initial kill. So this is the rationale behind our dosing regime. In aminoglycosides, you can give once a day, because all your target is to give a good concentration, and it will achieve a good area under the curve, but it won't be above time above MOEC won't be as when you give frequent interval. The yellow, as you can see, it's above it will be above MIC, but then you won't have a peak. So we just target antibiotics. Clindamycin, for example, you give 4 times a day based on its mechanism of, usually it's above time above MIC. It's time dependent. So you give frequent interval. Likewise, beta lactams, you give 8 hourly. All your aim is to keep your antibiotic level 4 times above MIC. Whereas in case of aminoglycoside, you want to give the maximum, but make sure, because they are toxic agent, make sure you are sub-toxic levels. So this is in short how you describe the time kill. As you can clearly see, this is why I explained colony forming unit earlier. This is how we measure. Here we take example of Pseudomonas aeruginosa against each antimicrobial at constant colony forming unit. Initially, we incubate with 6 colony forming units, and you have a different antimicrobial MICs. You have concentration of 24, 16, 4, and based on that, as you can see here, when you have 24, the kill is maximum. For Cipro, it's in between ticarcillin and tobramycin. Ticarcillin is an antibiotic which we used to have. It came as timentin, ticarcillin with clavulanic acid. Very helpful antibiotic when it comes to Stenotrophomonas maltophilia. But now it's not available in UK. I don't know whether it's available in India. It's a nice agent. But here, all we are using it as a beta lactam. As you can see, the maximum you achieve is above 4 MIC. MIC above 4, you have good kill. After that, it's neutralizing. As you can see, it doesn't matter whether you improve your MIC. But whereas when it comes to aminoglycoside, you see a significant difference. Same here. As you can see, please notice this one. You have a neutropenic mice. I is used as a site of tissue injection, and you observe how much colony forming units come down. Why you use neutropenic mice? You just want to get rid of all the confounding factors. This again, I want to reiterate. When it comes to antimicrobial, simple cystitis treatment or lower upper respiratory tract treatment, what you are relying is patient's own immunity most of the times. The initial, you can give 3 days of antibiotic, but then ultimately you are looking at patient's immunity, own white cells to take care of. That's what we are trying to avoid here. So as you can see here, the higher the concentration, tobramycin, you see the kill is better. And then here, when you combine both imipenem and tobramycin, as you can see, there is a synergy in post-antibiotic effect. This is what we try when we treat endocarditis. So the same thing this is a frequent trend we see in our ITU. Initially, when patients come in, you will have a naive Pseudomonas, and then 7 days later, you will find selection pressure. As you can see here, there is resistance to meropenem, resistance to imipenem. This is a typical pattern you see. This is selection pressure. There are ways we can try get rid of this, which we will come later. And likewise, as you can see here, the same penicillin is bacteriostatic when the free antibiotic concentration available is around 30%. But when you increase that to 50%, it becomes bactericidal. This is what in the recent guidelines, endocarditis guidelines, what they suggest is just using one beta-lactam agent rather than earlier we used to have aminoglycoside, a second agent. Now, if you look at the most recent guidelines, they go just with the beta-lactam agent like Fluclox for Staph aureus. Likewise, they do this recommendation, and the thing is, you have to increase the dose to achieve this amount of percentage. The next one is time above MIC. As you can see here, gram-negative kill. If it's more than 50, as you can see, its colony forming unit comes down less than 0, which means literally it is killed. So this is again using the murine time model. We are predicting. And of late, as I mentioned earlier, CLSI, they have just reviewed their breakpoints. This was the earlier MICs for Kefipime. Now they have moved it. This is called susceptible but dose dependent, which means you have to increase the dose in order to achieve clinical outcome. And this is because of this concept of mutant prevention, which I mentioned earlier. Based on that, they just want to avoid any new resistance developing, so that they now move the goalpost in order to achieve this. And same thing with staph aureus. Earlier I mentioned vancomycin and the staph. It no just triggers the accessory regulator gene, so that the organisms, there is an MIC creep. What we need to do is give a decent dose of vancomycin, which is 750 milligrams BD or 1 gram. At this, as you can see here, you don't develop any mutants. But then when you lower the dose, you see clearly there is a mutant development. So this is what, so that you need to achieve the ideal target, but then you should not go, that is vancomycin, since it's a toxic agent, the therapeutic limit is very, it has a narrow therapeutic window. So now I go through few cases, clinical cases, just to give the use of uh, pharmacokinetics and dynamics in treating few Staph aureus bacteremias, and I have a fungal infection as well as an example. Just this is a patient who is a 78-year-old lady. He came in with a history of off legs for 5 days, a weakness of legs with back pain. She was unable to weight bear, no history of headache, photophobia, and excessiveness, so no meningism. And she gives complaint of chronic neck pain 30 years, low back pain for 30 years, as expected in elderly. She is type 2 diabetic, diet controlled, has essential hypertension. General examination, respiratory rate is normal, pulse rate increased, blood pressure is 149/70, oxygen saturation is 95%. She is febrile, had facial flushing, CVS, she has a systolic murmur in the aortic area, abdomen soft, RS clinically normal. Central nervous system, there is a lumbosacral area tenderness. They queried the infection. Final impression is they queried some kind of infection and suspected some kind of infective etiology, queried discitis or endocarditis based on her presentation. They sent a blood culture. As you can see, we grew Staph aureus, the blood culture sent on June 4th. And then we always recommend when you have Staph aureus to repeat blood culture. The cultures came positive on 5th and 7th. This is, she was started on Fluclox on 4th. In spite of being antibiotic, you are getting Staph aureus again. This is what we call as breakthrough bacteremia. When you have breakthrough bacteremia, what you have to look for some kind of deep-seated source. There is more likely you have some kind of deep-seated source. That's the example I would try to bring out in all the three Staph aureus bacteremias. So radiology, X-ray was normal, and lumbar spine. Initially, we have a policy. If you have a patient identifier is not there, they will reject. So it was rejected and then repeated. They found a wedge compression fracture of L1, and they did an MRI on the 8th. This is without contrast MRI, no evidence of discitis at any level. And then CT scan abdomen pelvis, you had a bibasal pleural effusion, bilateral lower lobe consolidation. On the CT head, no significant abnormality seen. She had an isotope scan. Again, it reflected the earlier finding, L2 compression fracture. Transthoracic echo was no obvious finding. And then transesophageal echo picked up this aortic root abscess. So when it's aortic root abscess, again, we have to apply the pharmacodynamics and pharmacokinetics since that's the topic. You can give Fluclox. Here you have Staph aureus, 2 gram QDS. If it's simple endocarditis, you can give just Fluclox for a longer duration, say 4 weeks or so, and then repeating echo. If the vegetations disappear, then accordingly you can stop the antibiotic duration. But here, if you have an aortic root abscess, you go for surgeons, whether they can do surgical intervention. If not, you treat with antibiotic. This patient is an elderly patient. Because of that, she refused surgery. So we have to sort out with antibiotic. Initially, she was commenced on Fluclox and gentamicin, and she had a hospital-acquired pneumonia on 10th, and she was given comoxiclav for that. And on the 11th, we changed the gentamicin to rifampicin. And since the aortic root abscess was confirmed, we continued the rifampicin. So this is a white cell trend. As you can see, after rifampicin, it will come down nicely. In spite of being on fluclox, you won't see much. This is because I need to explain a little bit on this. When you have an abscess or a deep-seated collection, your beta lactams, they expect the cell wall to be rapidly dividing. So in an aerobic environment, all these organisms, cell wall will be multiplying. It's a dynamic process. When you have a rapid cell wall multiplication, then your beta lactams will work well. But deep within the abscess, you have anaerobic environment. And here, now these days, we have this concept of biofilm quorum sensing, where what happens, there are auto-inducing peptides. These are all signaling molecules called quorum sensing, and they sense there is anaerobiasis. The all no bacterium, they are quite intelligent, and they move into a phase called in your microbiology, you might have read about stationary phase, log phase. So they move to latent phase, where they bring down their metabolic rate, their multiplication goes down. So the cell wall turnover again is brought down. Because of that, the cell wall acting agents won't act well. For this reason, you need to use rifampicin. Rifampicin acts on gram-positive biofilm. Likewise, ciprofloxacin acts on gram-negative biofilm. So this is the concept of adding rifampicin. Likewise, I earlier mentioned about the volume distribution. When it's above 14, your antibiotic is likely to be intracellular and will achieve your target tissue concentration. That's the reason you're adding rifampicin. So CRP, again, as you can see, there is a blip around the hospital-acquired pneumonia, and then it came down nicely. So in this patient, because she was elderly, she didn't go for surgery, and we gave antibiotic for 6 weeks, followed by a oral therapy. She was discharged on day 52. She was doing fine. And case 2, again, it's a diabetic patient, came with lower back pain, extending to lower limb, and patient complained of this pain. It's more of muscular in nature, and the patient also had a swollen left eyelid, conjunctival suffusion. Had the patient saw the GP. Just a minute, I'll have some water. And there was no improvement in the patient's condition. Past medical history, patient is a known type 2 diabetic, also hypothyroid. The thyroxine was around 150. They gave thyroxine of 150 milligram once a day. She was also on simvastatin, candesartan, and analgesics and sedative. General examination, she had, in UK, we give consideration to tattoo because some of them do develop hepatitis if done in not sterile conditions if it was done. So we do in general examination. This is one thing we do take care of. And blood pressure and pulse was normal. She was hot, subjectively feeling cold. So she had a rash widespread on the chest, abdomen, and both lower limb. CVS, RS, and abdomen was normal. She had a renal impairment, significant renal impairment. Central nervous system power and sense tone appears to be normal. So these were the plan. She was asked all the investigations to be done. And the impression was she had acute kidney injury due to the drug she was on. The plan was to stop all medication, get orthopedic opinion for the back pain. And on 13/7, the observations were the temperature was normal, pulse rate was 110, BP was normal, abdomen slightly distended. The acute kidney injury was explained to the medication she was on. The team suspected query discitis, query biliary sepsis, and they initially started comoxiclav as per hospital protocol, done blood culture, repeat all the blood screens. All the imaging was requested. as you can see, their urine grew as staph aureus. Sometimes it can be just confounding factor. Urine staph aureus, you have to be a bit skeptic. It's very, but you can get urinary abscess, which can lead to bacteremia. As you can see, on 12th, she had a staph aureus in the blood culture. We requested a repeat blood culture. And again, here it was again a breakthrough bacteremia. So there is something deep seated. Since she had a rash, we also tested for Panton Valentine leukocidin factor, which came back negative. And chest X-ray was normal. And USG of kidney was also normal because of the urine staph aureus. We did ask them to check whether there is any renal abscess or hydronephrosis, anything like that, which was ruled out. MRI, thorax and spine. This is without contrast. No evidence of discitis. And then pelvis, X-ray pelvis appeared to be normal. As you can see here, with contrast, she had a epidural abscess seen. And it's quite interesting. At this time, I worked in a hospital called Chesterfield, where my colleague was also a TMC alumni. He is called Dr. Bala. He's now in Qatar. And we used to interact closely with microbiology. Often when you have any abscess, want intervention, sometimes surgical team will be a bit reluctant. So source control is very important when it comes to any abscess or and you can bring down the duration of treatment as well, which for which Dr. Bala was very helpful to me. Whenever we had any deep-seated infection, I will go straight to him, get the patient listed in one of his list. It is there is a huge waiting list in UK. It's very difficult to get into it, but because we were colleagues and we were belong to same college, sometimes I do ask him for favor. It was a good time having him, and he provided all this MRI. As you can see here, there is a clear-cut epidural abscess, and all the slice, the images was provided by Bala. And the impression was L5, L1 intraspinal abscess with an epidural abscess behind L5 vertebra. So patient was commenced on Fluclox and clindamycin, 600 QDS, and she continued the antibiotic. We asked for, usually we get spinal surgeons involved when you have this kind of patients. And she had antibiotic for 8 weeks, and then she was transferred to a nearby neurosurgery referral unit in Sheffield. So white cell, as you can see clearly, with antibiotics, it came down nicely. Same CRP trending down nicely. And the third patient, this is an IV drug user. In UK, this is a classical trend you see in ITU. For every 10 beds, 3 will be either IV drug user or it will be alcoholic. And but we do give the same amount of care as normal patient, and we treat them quite respectfully. And as you can see here, patient came with the right groin and the right thigh, that is injection site infection. And she also complained of fever, cough. Initially, she met with the outpatient. They gave amoxicillin erythromycin, didn't get better. So she came back in 2 days. And she's a smoker on methadone rehab. She had a previous DVT in the left leg, and also a patient with bronchial asthma. General examination, all the pulse rate, VP, respiratory rate was normal. And CVS, RS. In the RS, she had bilateral crackles. CVS, she had a systolic murmur. Likewise, right groin, she had this injected site, no abscess. So impression was right lower limb DVT with a partially treated respiratory tract infection. So blood cultures sent, she had a staph aureus, sensitive to Fluclox, rifampicin, and Gent. And repeat blood culture came back negative. With IV drug users, this is a problem. They are not consistent, they are not compliant, and they will abscond and then come back. It's very difficult to treat, but to contrary to what expect, because of the frequent staphylococcal infection, they have good antibody titer. Sometimes you will find it quite, if this were a normal patient, they will succumb. But IV drug users, for some strange reason, they thrive well. And this patient, as you can see, came back again after July. In September, patient was back. And as you can see here, we had 3 sets of blood culture with Staph aureus. And this is a chest X-ray. As you can see, there is a bilateral nodularity, and especially here you can see a loculated a small. It's a pneumatocyl. Likewise, she had bilateral nodularity. Because of this, in endocarditis, right-sided endocarditis, you have septic emboli covered into lungs. And you give this. So this patient was suspected to be right-sided endocarditis, which you expect in IV drug user. And transesophageal echo showed tricuspid valve papillary muscle rupture with tricuspid regurgitation. And there was a mobile mass consistent with vegetation. She had a repeat echo and the size has increased. The patient deteriorated, to be honest. We didn't couldn't get on top of her management because of patient's non-compliance as well. And white cell trend, this is a white cell trend. And CRP initially came down nicely, but patient had too many complications. Initially, she was commenced on ceftriaxone and clindamycin, and then switched to fluclox and rifampicin. So she was discussed in MDT, and we did discuss about her overall prognosis as well as management of right-sided because of all her underlying issue, and she was not giving up her habit. They just wanted us to manage with antibiotics, no surgical intervention, and she was not a candidate for surgery. She was given 6 weeks of antibiotic, and again, she became quite worsened further. And as you can see, afterwards, she developed a wedge-shaped consolidation of the right middle lobe, and we couldn't do much. Her outcome was not as expected. But key messages when it comes to staphylococcal infection is you give adequate dose of antibiotic for appropriate duration. Initially, when you have all these patients, we look back, and if you look at when you initially treat a skin and soft tissue infection, you give antibiotic for adequate duration appropriately. The thing here is in UK, GPs they try to be conservative. Usually, even if it's QDS dose, they go for fluclox. Fluclox, when it comes to tissue penetration, if you give IV, it's a good antibiotic. But if you give oral, the bioavailability is low. This is where we are. No, this is our discussion. All this discussion we are going through today. It's all about the tissue availability and tissue penetration. So ideally, you have to treat initially when you find the infection. If you treat appropriately, you won't get deep-seated infection. So next, we go for antifungal. I will just give a break. Any questions at this point?
There are many questions in the chat box, sir. I think we are also exceeding time. So,
all right.
Probably we can go through the antifungals quickly and then take it in the 10
minutes. That's fine. I'll just finish through the antifungal. Yeah. When it comes to antifungal, it's the same. You have some which like amphotericin, which is Cmax, concentration maximum, and then you have time above MIC, which is usually azoles, and echinocandin and flucytosine fall. Flucytosine again is Tmax, time above MIC. Echinocandins are like intermediate category. So here again, you have a post-antifungal effect. And this is the example I took. We had this patient, a 66-year-old male. He came in with past, he was admitted in April, and he came in with breathlessness for the past 2 weeks. He was diagnosed previously. He is a chronic lung disease patient with pleuroparenchymal fibroelastenosis, and he had bilateral pneumothorax. He had drain bilaterally as well. The left side, it all settled, dried up, but the right side, it continued draining. And as you can see here, he had a empyema of the right side. They sent cultures. Blood cultures were negative. Sputum was normal. Serum galactomannan assay was very high, and right pleural fluid grew an aspergillus. Consistently, the patient grew pleural fluid, grew aspergillus. What I wanted is usually it will come from the lung. So you need a respiratory sample. I requested sputum. Both sputum, BAL all came negative consistently. Three samples were sent. And the reason we repeat when it comes to aspergillus is it can be a contaminant. Just one sample you shouldn't decide to treat, and it can be a contaminant. But this patient, I went to the ward. He had a drain full of pus. The bag was half filling each time. He was coming up with almost 100 to 200 mils each day, which was quite for the patient. But he was sad. He was doing all right. So the plan was, I suggested to start him as aspergillus empyema with aspergillus. What you will have is, I've seen a previous patient. That's why I was very convinced this should, because you are getting no respiratory aspergillus positive, but only the pleural fluid is coming up with this. The classical treatment will be a thoracoscopy. If you look at, there will be fungal plaques in the pleura, and ideally, if you can instill antifungal agent intrapleurally, that is the ideal management. But this patient had a bronchopleural fistula. Because of that, the team refused intrapleural administration. So we went with voriconazole. Voriconazole, when it comes to voriconazole, the thing is usually immunocompromised patients are the ones who get aspergillus infection. And voriconazole, it's a typical, they will be on immunosuppressant like tacrolimus, mycophenolate. And these two are nephrotoxic. So this is a conundrum when it comes to treating patients with aspergillus infection. In this patient, he was discussed in the national MDT. They came up with this diagnosis, necrotizing aspergillus empyema. He was commenced on, his weight was 100 kilogram. Because of that, he was commenced on loading dose of 600 BD IV, followed by oral 400 BD. This patient is still in our ward. He is due to be, we did add annular fungin as well for synergy, in addition to the voriconazole. And then he's due to be sent home on, he wants to go home. So the voriconazole is going to be stopped and switched to posaconazole. He didn't have any side effects of voriconazole. We did check for CNS toxicity, visual disturbance, all issues. He has tolerated very well. He is doing all right. But then the prognosis is very poor. So this is the X-ray of him. As you can see here, there is a chest drain. This is the site where the pus is coming from. And this is a white cell trend with him. CRP, and then we did liver function test. The pharmacology team was very skeptic because of all the toxicity profile. And initially, when the LFTs shot up, they were very reluctant. And then, as you can see, you do expect that. And subsequently, it will come down. So, yeah, just go through aspergillus place. So this is when you grow in the Sabarans dextrose agar, it will grow very well. There will be greenish, light green colonies. And then in Sabarans ducts, it will look like this. And as you know, they are conidiospore, and they are inhaled. The interesting thing about Aspergillus conidia is its critical size is less than 5 micrometer. It falls at the exact size where it can enter lower lung fields. Whereas Aspergillus niger spore, they are larger, greater than 5 microns. So usually you will get otitis externa, but you won't get usually you won't get lung infection with Aspergillus niger. And usually patients will be on corticosteroids. Corticosteroids are like growth factor for aspergillus, so they will thrive very well. Likewise, patients will be neutropenic. You need good neutrophilic response to kill off this gonorrhea initially. If left, I think it will go in for invasive aspergillosis. So this is in short. And then there is this usual consideration where I mentioned earlier, whether go for continuous infusion, what are the benefits for that? And then meropenem as well. With Pseudomonas, as you treat, you'll have selection pressure and development of MIC creep with meropenem. Again, for this, you can go for continuous infusion, but because of the product stability issue, it's a bit tricky one. Lastly, vancomycin. This is what I want to stress. Area under the curve, you need to achieve above 400. This is what. When it's below 400, it's not therapeutic. But when you go above 20, it's toxic. So this is a narrow therapeutic range. But you need to achieve area under the curve by MMC of more than 400. And then gentamicin, which you all know, I just ran through that. You have two nomograms, one for 5 milligrams and then one for 7 milligrams. That is Craig Urban nomogram and Hartford nomogram. And in cases where, like endocarditis, you are using synergistic dose, where you just go for less than 1 milligrams. Less than 1 milligram is for when you use the nomogram, whereas 2 milligrams is when you use multiple dosing, which usually is 1 milligram per kilogram, and that's for synergy with beta lactam. As you know, streptococcus are intrinsically resistant to gentamicin. The reason you are adding in case of endocarditis is for synergy, not that gentamicin is active. Gentamicin is active against staphylococcus, but when it comes to streptococcus, they are intrinsically resistant. So, for example, enterococcus endocarditis, you do add, the guidelines do recommend adding gentamicin as second agent for 4 weeks. The reason is synergy, not the aim is you rupture the cell wall, and then the aminoglycoside will act after the cell wall is ruptured. Again, there is a goalpost move when it comes to quinolone. Now they recommend when you have interim, there is a large, huge bracket which has been brought under intermediate. Intermediate, you have to give 500 TDS or 750 BD of Cipro, which usually we don't. And that's in short what I was trying to bring. And likewise, when you don't give this dose, when the MIC is high, probability of cure is low, which is what I wanted to reiterate here. And just for your reading, there is an article which I mentioned. Thank you. Sorry, Venki, sorry to breach the time limit. It's a bit
Sorry,
longer.
it's all right, sir. It's an excellent, exhaustive account of both the PK, PD, and actual real life case scenarios in complex circumstances. Thank you so much for the extensive lecture. And there are questions in the chat box, sir. We can take it, and after that, we can open it for the audience for their comments or further questions. So, regarding the dosing and the concentration of antibiotics, Dr. Balamurugan Srinivasan has posed, what about urinary tract concentration of antibiotics? What kind of antibiotics are preferable in the urinary tract infections?
Urinary tract, it depends on how you define. Is it a lower urinary tract infection or upper UTI? When it comes to pyelonephritis or a renal tract abscess, anything like that, you are looking at a longer duration, and usually 14 days, 10 to 14 days when it comes to hydronephrosis, pyelonephritis, like that. And then source control is important. And antibiotic choice, it depends on sensitivity testing. Urine, you can always test, and depending on the organism, you choose the antibiotic. And usually in UK, we use most often trimethoprim, nitrofurantoin as a GP choice, empirical choice for simple cystitis. We go for that. And when you get ESBL, extended spectrum beta lactamase, likewise, if it is sensitive to pivmesalinum, we use pivmesalinum. And pivmesalinum is another agent, pharmacodynamics and kinetics come in, where earlier BNF used to recommend not to use when the EGFR is very low, because it's concentrated, its concentration in the urine comes down, and its activity as such falls. Pivmesalinum doesn't work. For this reason, you need a good renal function to use pivmesalinum. and osmolality changes its sensitivity. There are a few other things with pimistrum. It's an interesting antibiotic. Yeah. Likewise, there are other choices. Intravenous antibiotic, when it comes to renal tract infection, you use cephalosporin, cefotaxime. Cephalosporins are good if it's sensitive. In UK, we usually have naive isolate sensitive, and when you have very resistant isolate, you go for carbapenem. Like if, depending on the resistance mechanism, ESBL you go for carbapenem, and then if you have CRE anything like that, no, you go for after sensitivity testing, you go for appropriate choice. Now we have ceftobiprole, all those choices depending on sensitivity you can use. Yeah.
Amongst the polymyxins, sir, in urinary tract infection for drug-resistant bugs?
Polymyxin, because of their nephrotoxicity, it's preferable not to use. But if you haven't got any other choice alternative, you can use colistin. But you have to be very careful, monitor the renal function, and while using colistin, we have to be very because of the narrow therapeutic index, we need to be careful. Yeah.
Dr. Neelakandan wants to know about flash antibiotics in surgery.
Flash antibiotics, is it?
Yes. So, Neelakandan sir, if you are there, you can unmute yourself and kind of elaborate on the question, sir.
Sorry. Even prophylaxis, is it antibiotic prophylaxis? Wow, I haven't come across the term.
Yes,
Flash.
sir.
I don't know what.
I think if Dr. Neelakandan sir is there, can you unmute yourself and elaborate on the question, sir? I think he's not there.
I think he meant giving like one dose,
Yeah.
when you're operating or something like that, Murugesh.
Yeah. The among the antibiotics, phosphomycin comes for urinary infection. You can use 3 gram sachet, which can be used as one. Apart from that, prophylaxis you can give. For example, MRSA, we do give 400 milligram start dose of teicoplanin, which is kind of prophylactic dose. And it's just depending on what surgery patient is going on and what type of cover you need. Yeah.
Dr. Panichami wanted to know whether there is a popular app to use antibiotics in different situations and to calculate PKPD.
It depends on countries. We have in UK, for each hospital we have a specific we have antimicrobial policy, and there is also app for our local hospital policy. But I don't know about when it comes to no, predominantly I can comment on UK and US. I worked in CLSI hospitals where they use CLSI as well. In US, they have Sanford Guide is a standard one, which if you have an app based on Sanford Guide, you can use that. Likewise, Cleveland Clinic, they have antimicrobial, which is very good. I think these are the two we often use. Apart from that, UK, we have this BNF. Likewise, we do have our own hospital apps which we use. I'm not sure what I could recommend for India. Yeah.
Dr. Balamurugan wanted to know, we usually advise to take ATT strictly on early morning empty stomach. We observed less efficacy of ATT when taken after food. What is your comment?
It's like voriconazole they recommend with fatty food. It's similar to that absorption. It's more of absorption of each agent has its own depending on the whether it's a cation or anion, and what type of pH you expect. The absorption is good. Suppose if you have a weak acid under acidic condition, if you take that, the absorption will be good. The corollary, you just take it that way. Yeah.
Dr. Nivedan wanted to know, in MSSA, vancomycin
Yeah.
is not superior to fluoroquinolones or third generation cephalosporins. Is that true? He wants clarifications on that.
No, not at all. I think flu clocks is ideal. We use in UK, we use flu clocks. In India, I think we have oxacillin, isn't it? I think flu clocks is the ideal agent. But if you can't use flu clocks, allergic to penicillin, then vancomycin is ideal choice. It is a large molecule. In my presentation, I did show there is if you have 500 to 400 to 500 Dalton, the antibiotic won't leave the plasma space. The vancomycin, it's around 1,400 Dalton. So because of its a large molecule, its tissue penetration is very poor. That's the only lacunae about when you have deep-seated abscess or anything like that. Within the abscess, penetration of vancomycin will lag. That's the reason you need to have a second agent. But vancomycin is a good agent. I mean, it's nothing wrong in using when you have a bacteremia or a deep-seated infection. But it's better to have a second agent along with vancomycin.
So I have a question, sir, regarding
Yeah,
Staphylococcus decontamination for chronic carriers. How is
yeah.
it done? Can you give us some pointers regarding that?
Usually, the way we do it in UK is we do screening, MRSA screening, and in surgical patients, orthopedic patients, we do look for MSSA as well, because that's the organism we want to give prophylaxis. So if you have a Staphylococcus from the nasal screen or from the axillary or groin, what we tend to do is we give preoperatively before surgery we try to decolonize. We use octanacin and body wash, which we have octanacin body wash, or if sometimes patients do have allergy, we can use mupirocin nasal ointment and chlorhexidine body wash. And we repeat screen, give it 5 days, repeat screen, give 48 hours interval, and then repeat the screen. If it's negative, then you can go ahead. If not, sometimes in some patients we go for a teicoplanin prophylaxis, and 1 hour after during induction you give teicoplanin, and then go with the procedure. Yeah.
Thank you, sir. There are so any comments, questions further from the audience? I think they can go ahead.
It was a wonderful presentation, Dr. Murugesh.
Thank you, sir.
I think we should have more of it, because this is a very vast topic which cannot be covered in one lecture. Or
I was a bit ambitious, I did think of cutting it short, but
we,
then
we we did pharmacology almost 3 decades, almost 4 decades ago, and at that time we used to talk a lot about synergism, then negative synergism or antagonism, which antibiotics you do not combine, bactericidal versus bacteriostatic. Do these still hold good, or?
there are centers where they still do that. For
Mm,
example, a place called Salford, where I work, we used to have checkerboard, where you have a cross match. You get patient serum in patients with endocarditis, serum bactericidal concentration. We get the organism staff, inoculate the patient's serum in serial dilution. At what cutoff it's falling off, and then you do this combination I'm mentioning, isn't it? Flu clocks with gentamicin. We do that in a checkerboard. You like a square. On serial dilutions, you have both flu clocks and gentamicin, and see at what concentration it's you get a good MIC. And we used to recommend that. There are centers that still
No,
do,
you are
but
telling in vitro. What I'm asking is a simple rule of thumb where right in the beginning we try to avoid some antibiotic combinations.
yeah, that's true
Does
as
it
well. No,
still
if
hold
you,
good?
yeah, it still holds good. For
Mm,
example, if you have a static agent like doxy
mm,
with a Cidal agent, like no, if you combine with a beta lactam,
yeah.
because it's static, it interferes with that. And then likewise, we used to have this amoxicillin with gentamicin. They do have you have to give it separately, or else one brings down others efficacy. You do have that, yeah.
You just want to comment. Very nice presentation.
Thanks, sir. How are you?
Yeah, very good. Happy to see you after a long time.
Yeah, it's nice meeting you. Yeah.
Yeah, and you made like very nice cartoons actually.
What was it, sir? Sir, I couldn't hear.
Your
Sorry.
cartoons,
Yeah.
the
The slides
pharmaco.
were very, very, very good. Illustrations were there.
Exactly. It is really nice actually.
It's we use for teaching, sir, here in UK, student teaching. So the thing is, we try to bring down the no, literary content and make it more pictorial, so that they are very attentive. This is the way we teach. We bring down, we make use of right-sided no, learning more than no, literary. We try to avoid all the left side. So the students here are like that. They have attention deficit. This amount of time, if I have taken, they no one would have listened. So we
That-
try it. Usually, our way of going is 30 minutes, followed by discussion. That's it. Not more than 30 minutes. I don't think anyone will listen.
I agree.
So
I think
yeah,
that's the attention span, right? They say anything lecture more than 40 minutes, like it doesn't, it's done. Yeah. And the
yeah.
other thing, Murugesh, we have been missing you in the case conference. I mean, you are a very, very good teacher. All your
Thank you,
case
sir. Thank you.
presentations and all have been usually very good, actually. Thank you.
Thank you, sir.
And I
There
think
are
Ajay has a very good question here.
yeah, there are a couple more questions. Should we take it and wind it up?
Yeah. Ajay, he's no, he's been from US. It's always he will come up with interesting queries,
Yeah.
and always thank you, Ajay. Thank you for the question. What is it?
Vancomycin with piptas causing incidence of AKI. What incident with this combination? What is your thoughts about it? Vancomycin with piprazolam, tazobactam, vancomycin causing AKI. What are your thoughts on that?
It's a true thing, because with piptas you are giving 4.5 grams. Already the kidneys are overloaded, and in those patients, the same thing with often you find in penicillin allergy, they go for vancomycin, gentamicin, and these combinations are no very very. If they go for that, they have to make sure EGFR is greater than 90, and each very careful, keep careful eye on the renal function. What they tend to do is they start the antibiotic, but then they're reckless on the monitoring, and that's where you get into trouble. With piptas, I think it's preferable to avoid vancomycin. Or what will happen? Vancomycin, you can give it as infusion. Um, I think vancomycin infusion, you can bring down the amount, dose, as well as toxicity target. Here in UK, we tend to use infusion whenever you have this kind of issues, and you can control the toxicity limit using infusion,
Okay.
continuous infusion. I mean.
Sure. Thank you, sir. Thank you so much. And thanks at some point of time, the audience number was almost 52, 53. And that's probably our highest in so far in the last 6 lectures. So that's a kind of encouraging, despite a pretty long lecture. So thank you so much for all of you for being here. And we'll soon meet you with another edition of an interesting topic. Thank you. Thank you all. Good evening.
Thank you, Dr.
Uh, th-
Thank you.
Thank you very much, sir. Thank you, Swami sir, Murali sir, and then Vengi. I especially thank you for all the diligent effort you take. It's very hard. No, I do understand in your very busy schedule doing this thing. Appreciate it. Yeah. Thank you very much.
Thank you. Thank you, sir.
See you. Bye.